data but graphically presented. So you can see the decline in each of them, gradual decline. Okay, when I update it, this if I update it with the last NDHS 2023-2024, I will notice, I will see what, I will update it to see where it will have gone by then. But this one you see from NDHS 2023 to 8 like that. Now there's a new one that is just out, so we'll put it to that. Okay, unfortunately, although understandably, Nigeria has the highest number of unimmunized children in Africa. Well, you can see about half, the graphic says it all. Half of the unimmunized children in Africa are based in Nigeria. There are several reasons that can account for this. One, our population is high. Okay, our population is quite high. And we also have reasonable resources, no doubt. But very importantly, apart from the high population, our healthcare system is a bit still vulnerable. And to make things worse, we would have done better if we had less of insecurity. Insecurity now is also now contributing to this problem. So that's where we are. Insecurity is also now contributing. So we need to up our game. And unfortunately, majority of these children are in the northern parts of our country. And that is where most of the insecurity is. Not to say that insecurity is not everywhere. It's everywhere, no doubt. The east, unknown gunmen, everywhere there is insecurity. Even in River State here, there are a lot of insecurity. So it's affecting immunization coverage. It's affecting immunization coverage. Okay. So we use DPT, we used to call it DPT, that's diphtheria, pertussis, and tetanus injection, antigen, but now it's penta 3 because of other antigens is now 5 antigens together, penta 3. We use penta 3 to assess immunization coverage. It's like a convention. So when we want to look at, say, what is the immunization coverage in Nigeria, one of the easiest things we can do is to look at penta 3 coverage, penta 3 coverage is just what we use, is what is adopted, officially adopted. Why as All right. Now, there are 5 types of vaccines commonly used, 5 of them. The live vaccines, in fact, maybe because of this network, let me off. The live vaccines or live attenuated vaccines, they are live viruses but weakened. That's the attenuation. Most times they are weakened with formalin or some other chemicals, or ultraviolet rays also. There are mechanisms whereby they are weakened. So when as they are weakened, they lose their ability to cause disease. They lose their pathogenicity, okay, the ability to induce or cause disease, or their virulence. Then at the same time, but at the same time, they do not lose their capacity to cause immune response. So they retain their immunogenicity and lose their pathogenicity. That is their characteristics. Examples are BCG, yellow fever, oral polio vaccine, and measles. The examples that is that in our schedule. If not, there could be other examples. We will limit ourselves to the ones our national program. Then we have killed or inactivated vaccines like the pertussis, cholera, typhoid, and the IPV, the inactivated polio vaccine. There are 2 types of polio vaccine, the oral polio and the inactivated polio vaccine that is injectable. Then you have the one they call toxoids. Toxoids, diphtheria, tetanus. Toxoids are the ones that are made from, the components of those bacteria. Then you have the conjugate vaccines like pneumococcal conjugate vaccine. Then you have recombinant vaccines, hepatitis B, human papilloma virus vaccines. Those are recombinant vaccines. So they are in groups, okay? These are groups of vaccines where you could just, then this is immunization schedule. Immunization schedule. A lot of you who are healthcare workers, well, you just look at them. Most of them, some of them are being modified again. Some of these things are not cast in stone or in marble, as they say. The reason is that based on epidemiological evidence, countries can modify them. Even in our own country, we have modified. You see, we have, like now, we are now giving a second dose of measles. But for many years, when I even in practice, measles was only at 9 months, but now, so it can be modified. Okay. Then the current immunization strategies we have 2. One is the routine or basic immunization. I should have called it number 1. Routine or basic immunization. That is this one, routine or basic immunization. That is this type of immunization or vaccination children have when children are born. The parents, the mother in particular, takes them to the health center routinely every month to receive vaccines based on the schedule of appointments. That is basic immunization. So the strategy used to give those ones are fixed post strategy. The hospital, the health center, the health facility is the fixed post. We can also use outreaches to give these ones, whereby the healthcare workers take these vaccines, go to the communities, go to where the people reside, and give to them. Then the other approach is the supplemental immunization activity taking place, right? Over the maybe weekend, you see healthcare workers with their aprons and their vaccine carriers moving about and vaccinating children. So the supplemental include For oral polio, for polio eradication, we use the NIPDs, that is National Immunization Plus Days, where the entire nation declares immunization, then we use the state immunization clauses. Initially, it was NID, Initial National Immunization Days, but later it was changed to NIPDs because of the monotony, in the sense that a lot of people started preventing their children from receiving the vaccines. That eating not too much every time, this same vaccine. So in order to make the vaccine program attractive, other things were now introduced. For instance, deworming the children, giving them what do you call it now? This food supplement, vitamin A supplementation, okay, vitamin A, and use the opportunity to distribute a few drugs like oral rehydration salts and all that to mothers. So that is why it's now immunization plus days. Then you can, if it is if it is the country-wide, it becomes national, state, it becomes state or local government. Then there is something called a mop-up immunization. Mop-up immunization happens also when in certain situations, maybe a sudden outbreak of a particular vaccine preventable disease in an area, a vaccine preventable disease that is epidemic prone. Maybe it just happens somewhere in Port Harcourt, but we immunize the entire River State, because that is wherever it has reached, we just try to contain it at that point. So you can use some mop-ups. Then for measles, we have the measles campaign, but many of them now are all merged into this neonatal infant week, which I'm trying to remember the name, which we do annually, there's National Maternal Infant Neonatal Week, which we do. We do use the opportunity to do a lot of these immunizations, like yellow fever, tetanus, and all that, cerebrospinal meningitis, and all that. Okay, so that's for vaccine. Then for other non-communicable diseases, we have TB, we have leprosy. Oh, somebody saying no sound. Yeah. Maternal infant child, no, no, it's maternal neonatal child health week, yes. Maternal neonatal child health week. Okay, so we use this opportunity to immunize children. Okay, these are various strategies. Then we have the, thank you, I've seen the correct name. Then we have the TB, which is another major communicable disease in our environment. TB is a problem. Okay, it's caused by Mycobacterium tuberculosis, affects the lungs most often than any other part of the body, but that does not say that TB does not affect any other part of the body. It does. It does. It affects almost every organ. So TB is spread through the air by a droplet infection. Droplet, maybe through sneezing, coughing, spitting, right? A droplet is not airborne, it's droplets, it drops, it's not airborne, it's not spread in the air per se. If it pushes either through sneezing or coughing, it drops after a while because it is heavy. The molecule is heavy. That bacteria, the droplet nature, a lot of moisture, saliva around it, so it drops. The weight is more than 10 microns, 10 microns. So by gravity, it will drop. more than 10 microns. So it can be healed. So TB is a very serious disease, but very completely curable, right? So now there have been over time upsurge of TB because of course HIV. And because TB now tend to um, relate because of immune depression with HIV, wherever we suspect, wherever we see TB, we must screen for HIV. Wherever we see HIV, we must screen for TB because now both of them are like Siamese twins. They go hand in hand. With the advent of HIV globally, there was upsurge of TB. The simple reason is that many people are infected with TB, many in the society, but the TB has the capacity to be latent, can remain dormant in the lung or any part of the body for many, many years. So the body's immune system usually keep them in check. But if for any reason the immune system wanes, the immune system depresses, maybe some very acute illness occurs in that person or chronic illness, or gradually the person become aged and his immune status begins to weaken, to wane, then TB can come up, right? So that is, TB is a leading cause of people with HIV. It's a leading cause of death among people living with HIV. So for that reason, for among people living HIV, we used to now give TB prophylaxis. So most people who fall ill with TB live in low and medium income countries. But TB is present all over the world. TB is present globally. It's just that we have the high burden of it. And it's explainable. Our health infrastructure is weak. So our health system is weak. Now, about half of all people with TB can be found in 8 countries of the world. Imagine when we have about 198 countries, 50% of the people with TB are found in just 8. You can imagine that. Bangladesh is leading the pack. China, India, Indonesia, Nigeria, Pakistan, Philippines, South Africa. South Africa became prominent because of HIV. You see, about a quarter of the world's population is estimated to be infected with TB. Well, being infected with TB bacteria does not suggest that the person has a TB disease. Please take note. The same thing with if being infected with, if a blood test is done on almost all of us who are participating in this lecture, if our blood is sampled for malaria parasite, you can see that almost 90 to 100% of us will have malaria parasites. But that does not suggest that we have malaria. That's how it is with TB. They can be kept in check by the immune system, right? But when the immune system weakens for either because of one stress factor or the other, then the bacteria can have the opportunity to emerge. Only 15%, 5 to 15% of people fall ill with active TB disease. So you can see, while about a quarter, a lot of people will have it, only about 5 to 15% will fall, active disease. So they are all being checked. So the rest have TB infection but are not ill and cannot transmit the disease. Both TB infection and disease are curable using antibiotics. Okay, these are just facts about TB in terms of the numbers. Okay, so you can just read them up. So, but when it comes to TB, the greatest challenge we have is the MDR TB, multi-drug resistant TB. It remains a public health crisis and a security threat. Nobody prays to be classified or into this group. it is very difficult to cure and a more prolonged cure. Although the medical science has done, medical science globally has done a lot of work, a lot of research. When we started treating multi-drug resistant TB, even in our center here in Port Harcourt in about, I think 2014, when we started, I was involved in that center. Okay. The treatment was 18 months, 18 months. But today we are treating for 8 months. 18 months of hospitalization, compulsory hospitalization. 18 months of compulsory hospitalization to treat multi-drug. So that's quite, but today it's been reduced because of the newer drugs to 8 months and now referred to community management. You see, so globally, TB incidence is falling at about 2% per year between 2015 and 2020. And of course, now, so we say that it is falling. Part of the reason is that, now we have a better treatment strategy. This screening of HIV patients for TB, a lot of, enable us identify a lot of cases and the effective treatment, okay, effective treatment, rifampicin and yes, INH, isoniazid, rifampicin, and all the rest, ethambutol and all that. So there are drugs, but what the strategy here is that we never encourage people with TB to seek private treatment. No, it's a disservice. One, the treatment is completely free at no cost, or not 1 naira, absolutely free. That's what the country has done. Absolutely free. The reason is that for most important public health interventions, those ones that are a great risk to the society, they are treated free of charge. Because, for instance, if somebody has COVID-19 and he comes to the hospital to say he should pay 100,000, he say, I don't have now, I'm going home. And that going home means spreading it to other people. So the government are undertaking like epidemic-prone diseases are treated free of charge, treated free of charge. But the challenge you are now having is to get people to avail themselves to, instead, maybe because of stigmatization, some people want to go for private treatment, which is not advisable. Why it's not advisable is that in the public sector, these healthcare providers are specifically trained. For instance, in our department, our people are specifically trained. We run the DOTS clinic for TB. Our residents, our senior registrars are well trained on the national protocol on how to handle it. All the drugs are there. Everything is there. The training is from time to time. But somewhere in the private clinic, you see the doctor has not, apart from what he had in the medical school, in the past 10 years, not gone any training on TB, and he's the one managing. Then the person is booking to death, to mortuary. Yes, I say so because, you can't give what you don't have. That is one. Two, access to the drugs can be very difficult because these are drugs gotten from bilateral agreement, Nigeria and some of these other countries and the pharmaceutical companies. So they are not sold. They are not sold. It's not what you openly, you can have in the open market or whatever. It's not. You cannot. They are programmed drugs. So the best bet is to just go through the program, Okay, I will talk about the transmission is by droplet infection, okay, particles and all that, coughing and all that. So we have two types, the bovine and the human type, the bovine TB and the human TB. The bovine TB is the one that affects cow and pigs, all right? Okay, and the one that affects humans. So communicability. One interesting fact about TB is that patients are effective as long as they remain untreated. Once patients are not treated, they remain very effective. But the good news is that immediately an effective treatment is introduced, the infectivity, that is the ability to infect others, or the virulence, is reduced to 90% in 48 hours. It is reduced by 90%. So if maybe, which means once a treatment is commenced, the individual within 48 hours loses ability to infect other people. So if treatment is commenced, say for 100 TB cases today, by next tomorrow, 90 of them will not be able to infect people. Only 10%. And so this is only just telling us how effective those drugs are. Those drugs are very effective. In a short period, they can, they can make a lot of difference. While the incubation period is anywhere from 3 weeks to 6 weeks, and the disease is slow in development, so that if people do not take their time, you will not notice their development. But the clinical features, for any experienced somebody, will notice it. But most important clinical feature we look at is cough. Prolonged cough at least 2 weeks. Initially, we used to say 3 weeks, but you see, things are changing. That is why in medicine, we are always updated with a lot of training on training. Our trainings don't end. As long as you are there, it does not. Even today, I went through a training. Either somebody is training me or I'm training somebody. That's how it is. Those of us in the teaching hospital. Well, if you're in a private clinic, sorry for you. You will remain with what you know. After 5 years, you are a chemist man because you are not training. So we train and get trained. That's the way this thing is. So prolonged cough. Before we used to say 3 weeks, but evidence now suggests 2 weeks is enough. Chest pain, weakness, fatigue, and all that. However, there are some of them that can be controversial, which means you must be very careful, like night sweats. When the weather is hot, people can sweat. That doesn't mean that they have TB. So it's a combination of factors, or you see somebody who is sweating now, you say this person will have TB. No, please, there's nothing, nothing like that. So we need caution. Okay. So that is how it is. Now, the symptoms are usually mild, and that could make people not seek treatment early enough. And in the process, since they are not seeking treatment early enough, they spread it. That's the danger. Some of these, the public health concern. But very acute diseases will compel the person to take treatment. For very acute ones, you have no choice. Okay, diagnosis, there are a variety of diagnostic measures these days, but the gold standard still remains our chest x-ray, okay? Suspected cases, now there are other cases where we even use rapid tests like TB Lam, urine, even GeneXpert, okay, and all that. So these are tests that are recommended by WHO, okay, or sputum microscopy. Sputum microscopy is actually, is the gold standard, not chest x-ray. Sputum microscopy, that is the bacteriology, the culture. It takes time to culture, mainly because of the time. Most times when you collect the samples, you don't wait for all those things. It used to take up up to 4 to 6 weeks before you can culture it. People with TB sometimes do not show any signs of sickness. So that is why many times we also do screening when we are doing active case finding. We do screening at these patients that are at risk. As I said, patients with HIV, for instance, you screen to identify their status. So look at the methods: intensified preventive and control. One, intensified case finding, either facility or community-based case finding. Even in the hospital, we have active case finding. So from our general GOPD, our general outpatient, and all the entry points, A and E and all that, all the entry points, we do case finding using some checklist. Screening, we can use GeneXpert, TB-LAM, and all that. Then we can do tuberculin testing, Mantle test. You can use our drug treatment, which is DOTS. DOTS means directly observe treatment short course. Directly observe treatment short course. That's DOTS. Here, the aim is to directly observe the patient taking the drugs. That's how important it is. So, particularly in the first 2 weeks or thereabout. So we'll make sure we render the person in how do they call it? How do I put this grammar now? Inability, make the person unable to transmit the disease. Okay, make sure that so for us to be sure that because you can give some people drug, they throw it away. So we have to provide. We say, okay, bring water when you are coming. Bring but one small bottle water, 500 mils. You take the drug before us, things like that, just for the first a week or two. When we are now certain that the communicability of the disease is now impaired, then can release the person to be taking his drug. Of course, using treatment supporters, a significant order, that kind. Because the reason is that when people get better, people can be very sick of TB, extremely dying, and just 2-3 days, 1 week of treatment, they have come back to life. You will look as if they will get strong. At that point, some people can drop the treatment, and that can be dangerous. They believe that, oh, they don't finish it, I'm okay now, and all that. So for that reason, we use counselors, we use counseling and get a significant order who support this person at home with reminder, insisting that the person takes his or her drugs. Okay. Now, HIV, well, this is one we know a lot already about. And when we read, we can easily understand, because a lot is being said over the last couple of years because of the nature of the stigmatizing nature of the disease. Human immunodeficiency virus is a retrovirus. It's a retrovirus. This virus breaks down our human immune system by attacking the body's CD4 cells. The CD4 cells. And once the CD4 cells are attacked and weakened, once they attack, it weakens our body's ability to defend itself from other invading bacteria. Okay? So, and once that body is weakened in that essence, it gives opportunity for other infections. We call them opportunistic infection. Why are they opportunistic? They took advantage, they took the opportunity that the body is weakened to emerge, to manifest themselves. They took an undue advantage, because when the immune system was strong, they could not penetrate. So that's why we call them opportunistic infections. Like TB is an opportunistic infection in patients with tuberculosis. Fungal infections are also opportunistic, Then a lot of others, neurological disorders, and some unusual carcinomas, malignancies like Kaposi carcinoma, Kaposi sarcoma. Okay, Kaposi sarcoma is a skin disease or that is very rare, found in elderly and people suffering from very chronic kidney disease, cancers, and all that. But when we begin to see Kaposi sarcoma in young people, then it's as a result of depressed immunity. Okay, as a result of depressed immunity, it's a skin type of infection. So, but we know much about HIV. Transmission is by exchange of body fluid from an infected person, okay, to uninfected. And the body fluid include breast milk, blood, semen, vaginal fluids, and all that. Okay. Then, however, it is not spread by kisses, hugs, and any of this sharing of utensils and all that. Okay. It can also, of course, be spread from a mother to a baby if there is no opportunity for treatment during pregnancy. That is vertical transmission. If there is no opportunity for treatment, particularly it's spread mainly at the time of birth. Okay, so that is why many times when women are pregnant with HIV and are HIV positive, we opt more for a cesarean section. Okay, there are protocols for this, but these are clinical things. I don't think I should bother you with them. You are doing more of public health. Okay, so the statistics are there. The important thing to note now is that over the years, there have been a decline in prevalence of HIV. There's been a decline in prevalence of HIV, even in countries where there was high burden. Even in Nigeria, the last time I think we had is 1.4 million or so, 1.3 or thereabouts. So there's been a rapid decline over time. Now, the current target by UNAIDS is that is the 95, 95, 95 targets, 395. So the first 95 is by 2030 that at least 95% of the people should know their HIV status, right? Should have been tested and know their HIV status. The other 95 is what? Who knows? Who is in HIV programming among you? The other 95 should be what? Put it on the chart. Let's see. 95, 95, 95. Okay, go ahead, Nelly. Okay, put it. I don't know if you're muted, so just put it on there. Listen. 95 should know their status. 95 should be at least on treatment, and 95 should achieve viral what? Suppression. Okay, thank you. Well, that showed me there are programmers in the midst, so you know most of this. So 95, 95, 95 targets, that's what globally, that's what is a global target. So we are striving. You will see where we are as at the last count, I know. When we evaluated the 2020, Nigeria, we were able to achieve one target. That is, people living with HIV know their status. We're able to achieve 90%, right? when we were having 1990, that cascade. Then people living with HIV on treatment were not unable to get all. We were able to achieve 86%. But people living with HIV with viral suppression, we only had 72%. So we didn't meet quite the target at that time, but we're hoping that this time we'll meet the target. So our country is actually doing well. But there is a place we are not doing well, and that is in pediatric HIV. We are not doing well in pediatric HIV. We are still very, very, very low in pediatric HIV. Okay, so now in pediatric HIV, we look at the targets, estimated number of pregnant women live with HIV who receive ARV is just 44%. I don't know the exact what it is now, but I can find out. So so the risk is that if they are unable to receive ARVs and they are unable to have cesarean section, then there's a problem. Vertical transmission, transmission from mother to child, can occur. Then estimated coverage, ART coverage in children is still very low. While we're having 89% in adults, we're having only 45% in children. So we need to do more. Okay, we need to do more. Our strategic framework there, we have our national strategic plan, the AIDS-free Nigeria with zero new infection, zero AIDS-related discrimination and stigma. That's our national strategic plan. Zero new infection. That is incident rate zero. I told you earlier on that in some of the lectures earlier on that one of the ways we used to track a program is by monitoring the emergence of new infections. Okay, so new infections. All right, so these are just provisions of the strategic plan. You can take your time and read them. You have them already. Then hemorrhagic fevers, Lassa fever as a problem. Lassa fever is an acute viral hemorrhagic fever. It is caused by the Lassa virus and it's a member of the arenavirus family. Okay, this virus has caused a lot of epidemic in many countries: Benin Republic, Ghana, Guinea, Liberia, Mali, Sierra Leone, Togo, Nigeria, and other West African countries. It was first discovered in a place called Lassa in Borno State, and it was found it's a virus that usually occur in exposed food that has been contaminated by either urine or feces of infected Mastomys rat or Mastomys natalensis. Mastomys natalensis. That is the name of that rat. Mastomys natalensis, or the multi-mammate rat. From that natalensis, multi-mammate rat. But who cares? Who goes to begin to count the breasts? It's a multi-breasted rat. To go and count the breast of rats. Maybe those in virology and those can do that, not for us in clinical medicine or in public health. All we need to know is about, in fact, just avoid, we're not ready to count the breast to know whether it has multiple breasts or not. So here, the transmission is by person to person, and it can also, laboratory transmission can also occur. So any of you who is a laboratory scientist, you have to be very careful, particularly those in virology. You have to be very careful, it can be transmitted. So in healthcare settings, it can be, especially because of everything, poor PPEs, everything is inadequate, it can also, be transmitted. Okay, so that's it. Diagnosis and prompt treatment is essential. For now, there is no cure, no known cure. What is actually treated with the drug ribavirin? Ribavirin is not actually a proven remedy. So case fatality is about 1%. So it's not, the case fatality is not very high, but that is in good centers, but can be very high in, poorly managed centers. Okay. So this giving you about the key facts, the illness, hemorrhagic fever, 2 to 20 days duration, you can, the transmission rate and all that. So you can just read up this. So prevention is promoting first individual, household, community hygiene. Make sure food and other edibles are shielded away or stored in such a way that rats don't have access to them in rodent-proof containers. Okay. In some areas, Mastomys natalensis are very endemic. In certain parts of Nigeria, like in Edo, northern part of Edo, again, those areas in fact, that made the country to set up a Lassa Fever Research Institute at Irua Specialist Hospital. That's a major specialist hospital for Lassa fever. It used to just be Lassa Fever Research Center because we have so many of such in the world. And part of the reason is that people spread their food products on the street for drying and all that. And rats rodent from the bush take advantage to go and feed. In the process of feeding, they contaminate, and the people will go and eat those things. So family members should always be careful and avoid contact with blood and body fluids of people who are caring for the sick person. Even for those of us who are clinicians, normally, of course, in our department, it's managed in our center. It's managed in our center. Professor Maduka is the facility manager in our special treatment center for infectious diseases. So they are well kitted, everything is provided. The resident doctors who care for such patients whenever they come will make sure they don't lack any of those preventive measures because any of them could die from it. Some have died before, some of our doctors that I know very well from getting infected. So we need to, normally whenever we train them, we train and train and train. And make sure that they are familiar with the procedures so that they don't become victims. So we make all the PPEs available. We make sure the way the samples are taken, to the laboratory, make sure the laboratory, those, like we have a molecular laboratory so that where it can be analyzed. But for now, we make sample transport to Irua, but I don't know the latest. When I was in charge, we were using Irua, but I don't know if our molecular lab is now equipped to do it. Okay, so healthcare workers seeing patients suspected to have Lassa fever should immediately contact local and national expert advice. Once we suspect them, please, we must advise. We must report. No health worker is permitted to begin to manage. It's not the type of thing you manage in one private clinic and keep quiet. No. That is why when we are training our doctors, we train them well. Here I'm rushing. If in the usual clinical setting, we won't rush like this. We train them very well to recognize everything so that they can report to protect the society. And immediately an alarm is raised, the entire public health machinery is put in place in just hours. That can assure you we do that in hours. Maybe 2-3 hours, emergency meeting is called, machinery is put in place. And that is why in Nigeria we have successfully many times contained our epidemics once we have report. Then the COVID-19, well, I think here you are all experts about COVID-19. Read it up, Avec, because you are all adults. You saw it. A lot of you know what happened. You were using masks. You are maintaining distance. You are using, some of you use cloth mask, some of you use surgical mask, some of you use N95 mask. Okay, so here is COVID-19 is a coronavirus. 2019. That's actually what COVID-19 means. Coronavirus 2019, and that is just talking about the coronavirus species that emerged in 2019. So that's that name, COVID, coronavirus 2019. Okay, it's shortened to call it COVID-19. It's a coronavirus. There are several coronaviruses. It's just one of the, its common symptoms are fever, chills, sore throat, okay? And there could be a range of other diseases, fatigue, body pain, and all that, okay? A lot of people recover without actually needing hospital treatment or hospitalization. But some people, the sickness can be, this thing can become severe. It can become severe. The world lost a lot of people, okay? And a vaccine was hurriedly produced. Okay, I believe all of us are vaccinated. I am fully vaccinated. So but those of you who are not vaccinated, well, I don't know what you're waiting for. So it's always important to keep physical distance of at least a meter, 1.5 1.5 perhaps, because these things are average, based on research. Some are more. So in Nigeria, we are preaching 1.5 meters. A meter might be too small because we are not sure. We need to be more sure. Okay. Avoid large crowds. But at times it's difficult to avoid large crowd because you will go to church in a night vigil and all that. So, or you are in some of those crowds, or you are attending a political rally, for those of you who are in tune with those, So normally we advise that you use a properly fitted mask, maintain distance, and good personal hygiene, a lot of hand washing, okay, a lot of hand washing, and where it's not possible, use alcohol-based hand rubs. So, we were collecting sanitizers, the alcohol-based hand rubs and soaps to wash. It's always good to cover mouth and nose with, with the elbow when one is sneezing, okay, and all that. So these things are there. So thank you very much. I think that's the end. If you have any questions, you can quickly ask. Why did I say that is funny? Somebody is laughing. So you can ask, then we look at them. So that's it. Okay, so all right, so you can unmute everyone so that now we can ask questions and call it a day. We can mute, yes, so we can ask questions. So I'm okay, fair, okay, Peter, I did you do whichever, I'm sorry. Then after which Adekunle, Daniel, then Cyril Wale. Let's go in that order. Go on, unmute, please, host. Okay, I'm the host, oh. You made me host, okay. Let's see. Okay, mute on.
Okay, thank you, Prof. Good evening for
Good
the
evening.
sweet
Yes.
and wonderful college. Okay, I think, Prof, let me start by saying I learned a new and very important thing today. I was taught that tuberculosis is a born disease.
It's
I was taught that tuberculosis is a born disease.
no. It's not. It's a droplet infection. You know what is good? Look, please, all of you should look airborne, and is good to you are conversant with this terminology because people can confuse you. Don't allow them confuse you with their own ignorance. Airborne means it is carried anywhere. For instance, if a disease is airborne, it can from here go to England. It can go from here to China. There are some diseases like that, like SARS, severe acute respiratory virus, There are a few like that that are airborne. The avian influenza, they are airborne. But droplet is that if you go into the air, because of its heavy weight, it will drop. By gravity, if you throw something up, it comes down. So it will not go far. The same thing with COVID. That is why I say maintain 1 meter distance. I am saying, please maintain 1.5 or if possible 2. Because you know that if the person coughs or sneezes, that projectile that pushes it out will not remain in the air forever. It will drop under gravity because COVID is also up to 10 microns by weight. The other ones that are airborne are the ones that are 2.5. Those ones will call them respirable. Respirable. Those ones, when they are inhaled, they can go down to the alveoli of the lungs. Those are respirables. These other ones, they are like, you see, at times you see when you pass where they are burning something, soot, you look at your nostril everywhere, soot, good. They cannot go beyond those places. Remember, there was a time that soot, like in Port Harcourt, soot everywhere, soot, you see, they are not as dangerous as it was made to see by the media. But we who are in the, we know they are not as the media people project it to be, because we know technical characteristics of those particles, suspended particulate matter, or all those, SPMs. All right, go on, Adekunle Olarewaju. Unmute yourself and talk. Then go on. Let's call it a day.
Prof, thank you very much. I really enjoy your lecture, sir.
Thank you.
Yes, sir. So my question is still on tuberculosis, sir.
Okay, go on.
In the immunization clinic now, we are giving a BCG to children.
Yes.
Sir, after taking this BCG, is there any future occurrence that such children can still be reinfected with TB?
Thank you for the question.
Thank you, sir.
Really, after the BCG, the chances of the child getting TB is very rare. Is very rare, right? But it is possible. Let me tell you the teaching. The teaching now is that the TB protects the child generally from TB, but most protective of the child of complicated TB. There's a name for it. I'm just escaping. That is like miliary TB. There's something called miliary TB or TB encephalitis. Miliary TB and TB encephalitis. Those miliary TB and TB encephalitis are very severe forms of TB. So, in terms of theory, what you should now take away, and all of you from this, in case somebody asks you this question, and the question is that if somebody is immunized with BCG, can the person still have TB? The answer is what? Yes. But the person will not have severe TB. So in effect, in essence, that what do you call it now? BCG protects against severe form of TB. Do you understand? Severe TB. That is what it protects. Severe TB. And examples of is miliary TB, that is miliary tuberculosis, and TB encephalitis. Does that answer your question? Okay. So that is it. Next question, Cyril Wale. You have your question. If it's not there, let's have Cassie Davids. Oma. Because there are several. Open and talk. Are you unable to talk? So that I know where the problem. No, it's open now, so. Okay, now if somebody is not able to talk now, let's go now. What are we doing here? Christopher is saying.
Yes. Okay, sir, I'm back, sir. Hello, sir.
Go on, who is talking now?
Cassie is talking.
Good evening.
Okay. All right, go on, quick. I was calling. Go on.
All right, sir. So, sir, thank you for the lecture. So I was concerned about malaria, when we are talking about malaria.
Yes.
So you talked about that malaria is dangerous for pregnant women.
Yes.
Sir, please, I would have loved to know exactly why malaria is that dangerous for pregnant women. Then the second part of that question is this way, sir. You said that for children born from 0 to 6 months, that they have some level of strong immune resistance, so to speak, resistant of malaria. All right. So, but we are told, so to speak, that malaria even kills children in the womb. So I don't understand the should I say relationship now. A child in the womb can be cured of malaria, but when the child is born from 1 to 6 months, he has some level of immunity. So please, sir, can you shed a little bit more light, sir? Thank you.
Okay, thank you very much for your question. All right. You are saying that what was the first question, Seth? Because there are two. You talked about sorry. Okay, let me correct one this thing. I told you miliary TB and TB meningitis, not encephalitis. Well, meningitis can affect those are severe forms of TB that the BCG prevent. Okay, coming to malaria. You see, the malaria in pregnancy, it can lead to abortion. It can cause a woman to abort a child. Okay, and that is what is being prevented. It can lead a situation that contractions and expel the child. So malaria in pregnancy, malaria causes a lot of anemia. Okay, malaria causes anemia. That is the cardinal feature of malaria, anemia. It breaks down the blood cells, and you know that the most important function the blood performs is carriage of oxygen. Oxygen perfusion. Oxygen perfusion is one of the cardinal functions of the blood. So it moves oxygen to all the vital organs. So it can kill a child in the womb if a child is starved, of oxygen, the cells. The child is not breathing, but that oxygen is through the umbilical cord, right? Through the placenta. Okay, so that can occur. But when the child is born, the means of malaria in the womb and that when the child is born, they are not the same exactly. The child now needs to be beaten by malaria parasites, mosquito that will transmit the parasite. Okay. But at that time, I told you that by transference of passive immunity, you can see that some people suffer malaria more than others. I don't know if you have observed it. Some people can tell you that in the past 1 year or 2 years, I've not had malaria. Another person will tell you that they have malaria every month. Why? Their susceptibility, their immune response are not the same. We have categories of persons, maybe because of their genotype, they suffer malaria more than other people. So immune response matters a lot in any infectious disease. So because of that, when children are born, there is some form of immunity that is transferred from their mother to them. That's how God made it. That prevents some of those infections. But those immunity don't last. Okay? They are usually very temporary. And that is why we need to immunize the children by actively injecting antigens to them for their immunological substrates to produce antibodies, right? So when the child is born, he has that protection in the first 6 months. After that, that protection wears out. The child can now become very prone like any other person. Okay, so that's how it is. There are immunological mechanisms that are beyond this lecture. Okay, so that's how it works. But just believe it by faith because that's the truth. All right, the next person is Samira after Jerry, Gina, and Juliet. Quick, unmute yourself and speak. Ask your questions.
Good evening, Prof.
Good evening.
This question, Prof, thank you very much for the lecture. Still on malaria.
Okay.
You made mention of malaria vaccine not being 100% preventable.
Yes.
So why is it recommended since it is not 100%? And
no.
also, is a class.
No, do you have an alternative? So will you say, because see, let me tell you about science. Science is dynamic. And that is why there is research round the clock, round the world, globally. You can't wait until you have 100% before you roll out. Now, for instance, I said you're about 67%. Or maybe the research is still going on. Maybe in the next 5 years, right, either this very vaccine improved or maybe another one that has better efficacy, comes up. Look at when we started treatment with HIV, for instance. The drugs were so toxic and so, a lot of people left the treatment because it's like, I beg, this medicine will kill me, even the disease, because at that time they are not even feeling much of the disease, but The drugs were so toxic that you need to be very courageous to take. But today, with the current drugs now, we don't have problem. Look at our clinic full of people. With current drugs, people just seamlessly. The side effects from those drugs are so much that discourage people from taking them. But today, with with the latest drugs that are in use now, so you cannot say because it's like that, or no. Even if it is 50%, half bread is better than none. You can imagine the situation, okay, you gave 100 people that vaccine, 67 of them are protected. Okay, 33 are not. You can't say that, okay, until I wait until all of them. There is still work in progress. Let me tell you, most of the drugs you are taking, the efficacy are not 100%, in case you don't know. In case you don't know. Yes. Because you don't know what is you just swallow, it work for you, you don't know what is there. I know. All right.
Thank you, Prof. Please, Prof, what class is the vaccine among all the class of the vaccines?
Which one?
That is the malaria vaccine. What class does it belong? What type of vaccine is it?
Okay. Because it's Plasmodium. I'm not sure. I will find out. I will find out that I've not even looked at it. I've not really looked at it, but I will go to the books tonight, maybe, and if you remember tomorrow, maybe I can find out the particular type where it belongs.
Okay, thank you, Prof.
But it's not a virus, so it's either belongs to killed or inactivated. That's why I suspect, or a toxoid. That's most likely, but I will find out.
Thank you, Prof.
All right, thank you. Who is the next? Is this Samira? Go on. If you don't, then okay. Jerry Dina. Okay, Aisha Bawa. Okay, course rep.
So good evening.
Good evening.
Samira is here.
Okay, go on.
So please, during your presentation, you made mention of every individual has a TB bacteria in your system, but you need a certain condition when your immune system is being compromised. That is when the bacteria can be activated. I was told that anybody with HIV needs to take, without TB, needs to take TPT, which is the TB preventive therapy to prevent from not getting the tuberculosis, which is in the form of isoniazid. My question is, since we have the bacteria but it's latent, can we also take the isoniazid to prevent future occurrence? Thank you.
No need. No need. You see, in medical practice, drugs are given based on indications. Once those drugs are not given based on indication, it will cause resistance. That's why we don't. If it is latent, it is because, in fact, even that, it will not, you are just taking it for taking, so it will not do much. The reason is that, you see, because of our interaction in the society, we go to a religious crusade, we sing and shout in the churches, we ride in public transport, bus and all that. We go to stadium, people say, hey, man, and things like that, or gathering among friends. A lot of these things are emitted. We pick them up because they are microscopic. We pick them up in little doses. And our immune response, our immune status will just engulf them, our system will hold them. That is why when, for any reason, any person who is not reactive to tuberculin test, it's a danger in the society. We'll quickly give the person BCG injection. If, for instance, any among us will do a a MAN2 test, and the person is non-reactive, it means that the person is not in contact with TB bacteria. It's not even a good result. The person will say, it's not a good result at all, because immediately we look at that person as being a very high risk. Yes. Unlike the person might feel that, oh, I don't have anything. No, it's a misinterpretation of what it means. The person is at higher risk. It's better, it's reactive, which means the person has come into contact and the body system keeps it in check, and it can do nothing until the person dies, naturally. So that's how it is. Okay. When we give isoniazid or rifampicin, is maybe if there is high risk exposure. Where we see that somebody is high risk exposure, then that can be given for 6 months, and that's yeah. Okay.
Thank you, sir.
Swakelo Konsi. Go on with your
Good
question.
evening, sir.
Good evening.
Jerry Guinan, sir.
Okay, go on.
Still on TB, I was told that a child that is more than 2 weeks should not be given a BCG. And I want to know why, since it's a child immunizable vaccine.
Who said
Secondly,
so that child should remain unimmunized?
That it has exceeded the duration they're supposed to give a vaccine.
That one is native medicine they are practicing, not the medicine I know. That the child is a mother. Please discountenance that information. It's very wrong. Completely wrong. If the child is not immunized, you expose the child unnecessarily. It is best the child is given before the child leaves the hospital. The reason is that when a child is born, it's a joyous thing in the family. Everybody, mama, grandmama, they can transfer anything at that time. So we insist that the child should be immunized before leaving the health facility. But it can happen that, there are no vaccines at that time. That doesn't mean that child will not be immunized. I beg, whoever says that teaching is a witchcraft, very wrong teaching. I've never heard of such myself. And I'm a public health person.
Can a pregnant mother that is having TB take those TB drugs?
Of course. Of course. But remember what I said. We have TB control program, and it is monitored and is being implemented in the health facility. And also remember I said that our doctors, our nurses are all well trained. They are specially trained. They work in that maybe like you have not been taught, like our head of department, Dr. Mrs. Ojule. In fact, she's been head of TB unit in our hospital as far as I can remember. She's been trained nationally everywhere on TB. So you can never use her experience managing TB patients to compare with somebody in one private clinic that sees one patient once in 2 or 3 years and is not trained. So it's always advisable to go to the right professionals, because all these things are considered even more than most of the questions you're asking here now. Far more than it. Okay, next, quick, because I have to leave. I'm tired though. Let the questions come. I'm going to work. I left office at around 3, rushing home. I could get home 4 o'clock, come in 5. I needed some rest to getting ready for tomorrow. So ask your questions Okay, any person who raises his hand, I open and ask question because calling your name, you are not answering. So maybe just unmute yourself and ask questions.
Good evening, Prof.
Thank you. Good evening.
Prof, thank you for the wonderful lecture.
Thank
Mine
you.
is just about the HIV transmission. You said that the HIV transmission, HIV is transmitted through contaminated or infected blood products and dead body fluids,
Yeah.
excluding saliva. So it cannot be contacted through tissue. So I am curious. I want to know, is saliva not part of the body, or what is exceptional about the saliva that the virus cannot be contacted through kissing or saliva?
You see, the contact through saliva is not proven. It's not proven. Although people say deep kisses and all that, it is not yet proven. That is why it is not, if it is contacted, there are no cases that you say, oh, maybe the saliva touches you or anything, or maybe you know, it's not actually proven. That is why we cannot pin on it. We cannot pin on it. It's not proven. The ones that are proven are written out. There are some that are suspicious, but there are no concrete evidence that this person got his or her HIV because of through the saliva. Although these days, we have certain reagents to say through saliva, but remember that HIV is about antigen and antibody. The virus is the antigen. The reaction that emanates is when the body produces antibodies. And when we detect the antibodies that are specific for that antigen, we infer that that antigen is there. So it's like maybe you are going through, just imagine somebody going through a bush path and you see that, oh, these are evidence of tire. These are the landmarks of a tire passed through here. But you did not see the car. You did not see the car. But what you saw is those tires. And then you made the inference that a car passed through this place. Why? Because you saw tires. That is what happens with antibody antigen. It is the antigen that gives the infection. The antibody is the evidence that there is an antigen around. So if somebody did maybe saliva test, and that saliva test is an antibody test, you saw antibody on the saliva, does not mean that the antigen is on the saliva. So that is it. So I don't know if that analogy, I try to break it down, whether say that is what it is. So the antigen, if you want to assure the antigen, then you do your viral load. You see, just like a CD4, the CD4 count, they are reactive, the antibody test. The antibody test. That is why it's no longer used as, longer recommended as used to measure a tracking of the disease. Now we use direct viral load. You see, but viral load is expensive. The viral load machines are not everywhere and things like that. So at times you can still use this in way if you are in where no way, but the standard now is a viral load. So saliva is not proven. Next question. Next question. Okay, if there's no question, we'll call it a day. Good night, every one of you. We had a nice interaction. So see you tomorrow.
Good night, Prof.
Good night, yeah.